Good, good morning to everyone. Today I will be sharing some of the history of nursing from the earliest days through the current trends, as well as an update on the new essentials from the American Association of Colleges of Nursing. Our nursing history is very rich and gives us the path of our nurse ancestors who traveled while creating the role, the tasks, and innovations that occurred during the prior centuries to bring us today to the present. So let us begin. The objectives address some myths or inaccuracies that we have recently experienced during the pandemic, facts about Florence, and the rough road between scientists and governments. Then I will talk about who the first carers of the poor and the infirmed were, early nursing groups, the nursing in the New World with outstanding individuals who created new ways of nursing, the notables who created the foundation of nursing in my nation, and how we have progressed and where we stand today. I will discuss 3 myths or misbeliefs I have researched and will share. Disease transmission from animals to humans did not just start with COVID. Also, Nightingale nursing of the troops in Scutari did not prevent deaths of soldiers, as we often hear. And last, we'll discuss the scientists and governments which have been crossing paths and disbelieving each other before COVID, as we witnessed in the USA in 2019 and 2020. Diseases and their transmission. If you are interested in a history of civilization, you might want to read Guns, Germs, and Steel, The Fates of Human Societies by Gerard Diamond, who relates the details of how societies, when gathering to form communities and domesticating animals, diseases began to move from animals to humans. Also during the time of conquests, when one nation over the other during the colonization of the New World, diseases brought from the European communities often decimated the populations of the New World. Not long ago, domestic animals and humans lived together for protection and warmth. Smallpox, tuberculosis, malaria, plague are a few of these diseases. Cows have a disease called brucellosis, which when passed to humans is known as tuberculosis. One of the more well-known cases of animal-to-human transmission in recent times was HIV/AIDS from monkeys. The transmission and the ability to move to humans takes time for the micro or the virus to adapt to the new host, but this transition does take place and has been occurring for many centuries. Yes, Nightingale did go to Crimea, and she and the nurses accompanying her did eventually provide nursing care in the barracks of Scutari, but the outcome of decreased deaths was not due to nursing care. Reviewing the statistics following the war, she and Dr. John Sutherland reviewed the data and found that while she was in Crimea, the actual death rate increased. She realized then that the increased death rate was probably due to the poor sanitary conditions in the barracks. Therefore, she spent much of her time moving forward in reforming the Army medical services in Britain. Because of her popularity, there was a national appeal for nursing funds, and these funds were known as the Nightingale Fund, which was then used to open a training school for nurses at St. Thomas's Hospital in London around 1855. Thus, nursing and sanitation reform were Nightingale's contribution to health care and moving the profession forward. John Snow and many scientists over the years have had to fight to get policymakers to understand the science and the need to control of disease transmission. John Snow discovered that cholera was being transmitted through well water and that people needed to stop drinking the water coming from this specific pump on Broad Street. In 2020, in the USA, the battle between the president and Dr. Fauci demonstrated the recent conflict between science and government. Another conflict in the USA was also between the president and the Epidemic Intelligence Service of CDC, who was trying to get the government to understand that COVID was being transmitted by individuals who had no symptoms, and not just patients with symptoms. However, on February 27, 2020, all their messages were no longer able to go out as independent statements about COVID to the general public. This decision by the government had caused many lives that could have been saved if their discovery had been shared with all the citizens and the health professionals in our community. These are just 3 examples of how our history can clarify the misbeliefs or myths about healthcare today. In the early civilizations, the Roman Empire, the aristocratic women of these cities performed charitable works and cared for the poor and the sick. The next caretakers that emerged were from religious orders of Christian women committed to serving the poor and the infirmed. In the years that followed, many of the needs of the poor and the infirmed were the center of attention of the wealthy women of the communities. Often these women had a strong influence on beginning programs of caring and making change in the care of these people. Florence Nightingale is a good example of a distinguished woman of influence in training of women to become carers of the poor and the sick populations. Here is a brief review of Florence Nightingale. She was a fluent British woman. She was educated in her home and a family who were active in social reform projects. At 16, she had a visionary experience and believed to be called to serve others as a nurse. Because she did not understand the role of the nurse, she toured schools in Europe and hospitals, both in Germany and in France. Having learned the role, she went to school to learn about being a nurse. And after she completed her work, she was hired as a nurse. But in less than 2 years, she was asked to take nurses to Crimea to care for the wounded. And we know the rest of the story. History reveals how wars propelled the service of nurses through the ages, from the Crusades to Crimea and Europe to the Civil War in the United States. Care of the wounded soldiers was a major task for nurses. Nightingale's work in Crimea was the first time between 1853 and 1856 that trained nurses were called upon to assist in caring for the wounded. In the Civil War, Dorothea Dix was called upon to care for the injured. She was named Superintendent of Female Nurses for the Army. She was able to enroll 2,000 nurses to volunteer for service to take care of the soldiers from both North and South armies, which she insisted upon on her appointment. She also used ships on the Mississippi River as hospital boats. Clara Barton, another notable figure who went to the front lines of battles in the war to care for the soldiers, would go out at night to find soldiers who were still alive and bring them back for treatment. She was called the Angel of Battlefield. In other battles, she assisted in surgeries by administering chloroform during operations, and in 1865 she was named by Abraham Lincoln as supervisor of the Government Office of Missing Soldiers. Her team located 22,000 burial places and listed these and the names of each deceased. She also recognized the work of the International Committee of Red Cross in Europe and insisted that we start the American Red Cross, which was recognized in 1882 because of her insistence. Paul Starr, in his book, The Social Transformation of American Medicine, published in 1982, provides an in-depth analysis of how medicine evolved in the United States. He also noted some facts about the start of professional nursing in the nation. A similar pattern that occurred in Europe of the elite women moving to make change in healthcare also occurred here in the New World. It was the wives and women of wealth who became the guardians of a new hygienic order. They visited, inspected, and reported their findings of sanitation and the ventilation status of the hospitals. When they discovered patient care being provided by prison inmates in hospitals, these women urged the establishment of professional nursing in America. The physicians saw the value of nurses to assist them in their work, and with new scientific discoveries, they recognized that trained nurses were essential for them to complete their work. And so, hospital training programs began to be established by 1873. 3 programs were opened. By 1900, there were 432 hospital training programs, and by 1910, there were 1,129 nursing programs based in hospitals open. More notable nurse leaders in the New World are Lillian Wald, the first nurse to start public health nursing among the poor populations in New York City. She taught the people how to care for illness in their home. Also, prevention of disease through sanitation methods, and safety of well children by building a playground for them on their property of the Henry Street settlement. She also provided prenatal care for pregnant women, as she viewed this as the role of the public health nurse. Isabel Robb and Lavinia Dock were moving nursing forward, while at the same time, the American Nurses Association was established in 1897 and the International Council of Nurses in London in 1899. The training of midwives were being educated to serve the poor populations in rural and mountainous areas in the United States. When visiting their patients, they had to ride on horseback, as that was the only means of transportation. Also, early regulations started for hospital-trained nurses, which was introduced in 3 states in 1903. These were the first laws to recognize and guarantee that the nurses were educated and safe to care for patients in hospitals. Also, in 1909, Minnesota was the first university to bring nursing to higher education. On March 1st, a class of 4 students was admitted to the 3-year nursing program at the University of Minnesota. All other schools of nurse training in the United States were located within hospitals. It was not until the mid-20th century, with new scientific advances and several more wars, that nursing organizations made a concerted effort to address changes in nursing education and move to the academic degree-based programs. While at the same time, there was another effort attempting to shorten the time of nursing education. As the years passed, healthcare changed. Patient desires and demands changed. And with new scientific discoveries, such as the discovery of penicillin, infectious diseases were being controlled, so populations were living longer and chronic disease became more prevalent. Additional tasks were also handed over to nurses, such as the handing out of medications and the initiation of IV therapy. The role of hospital nurse demanded a more rigorous program, and this is including the sciences, liberal arts courses, psychology, communication, and these changes supported the move of nursing education to move to the university-based programs. The increase in leaders developing theoretical foundations in nursing came forward to support the discipline of nursing and move it toward a professional standing. Then, Dr. Ford and Silver developed the nurse practitioner program role, and from 1965 to 2000, the role expanded the nursing profession in education and practice. Nurses argued that it was selling out to medicine, only to be misproven when their role dominated and moved the nursing profession forward like no other influencing factor in the history of the United States nursing education. Nursing practice is a discipline, and nurse practitioners were practicing the discipline of nursing with the tools and the techniques acquired when assisting medicine. In 1960, Virginia Henderson's definition clearly identified the role of the nurse, and it stands today as a worldwide accepted definition. This is the first part of Henderson's definition, and the next part is, and to do this in such a way as to help him gain independence as rapidly as possible. This aspect of her work, this part of her function, she initiates and controls. Of this, she is the master. This definition from 1960 remains mainstay in many nursing definitions in education, in schools, and programs around the world. It has become a worldwide accepted definition of nursing, and no one has been able to improve on this statement. And we move forward in nursing in the United States. These are some of the most known and used nurse theorists, and focus of their theories are listed. You might say Orum's theory is closer to Henderson's definition by giving the patient the power to care for their health. The use of nursing theory as a main focus in educating pre-licensure students is no longer a strong part of their curriculum. The trend is to use more global theories for managing patient care, such as systems theory, economic foundations, political theories, and social theories, have become important in educating nurses to work in today's healthcare systems. Thus, it is important for the nurse educators to look more closely at the concepts we ascribe to each domain or content area of the nursing curricula. The student has to understand the vast array of settings and diversity of our patients and the range of the healthcare issues that are present in today's healthcare systems and their responsibility to manage. They must be problem solvers and understand how to take research and translate it into actions when caring for their patients. I mentioned earlier that nursing was trying to establish a college-based program in the mid-1950s that did not take as long as a university program. This was established and is called the Associate Degree of Nursing. The first year was basic liberal arts courses, and the second year and the third year were nursing science and practice. It mimicked the diploma programs of 3 years, but was based in college. And essentially, the addition of this program started what we call the ladder concept of nursing education, where students can move from lower levels of preparation to higher levels of preparation within the same system of nursing practice. However, the ADN program, or the Associate Degree of Nursing, and the BSN, the Bachelor's School of Nursing degree, all take the same licensing exam. In 1965, the professional organizations were upset and said that the BSN should be the first degree of entry into professional nursing practice. However, this has never been realized. The BSN moved into 4 years of courses, including the clinical or practice settings. The master's degree is focused on adding specialization to the practice field. The doctorate was for nursing researchers. This slide represents the levels of personnel caring for patients in our health system in the United States. The first level is the nursing assistant, and this person is certified by completing an examination, and this certification is usually part of the public health department's responsibility in each state. The next level is vocational or practical nursing, and they have organized formal education program, and they are licensed, and after successfully passing their examination, they can then practice. Each state also has a scope of practice for this level of personnel. The final level, and these are mandatory licenses, is a registered nurse, and it's a formal organized program usually based in a community college or university and successfully passing an national exam. And this is also mandatory. In order to hold a registered nurse license, you must have passed the national exam, and as you'll learn later, they must have graduated from an accredited school of nursing. There are no other mandatory licensure for attaining academic credentials at a higher level. Go from bachelor's to master's to doctorate. The registered nurse is the only level of required mandatory licensure that is required for academic preparation. At the University of Colorado, 2 colleagues met to discuss how they can assist the public health nurses from the rural communities to make better and safe judgments while they singularly managed their well-baby clinics. Drs. Ford and Silver discussed how to provide the additional knowledge and tools to attain this goal. 1 public health nurse and 1 pediatrician considered the current role and how to prepare the nurses to provide safe and competent care to the children living in the rural communities of Colorado. This new role started in 1965 and continues to migrate around the world in nation-states seeking to improve health care for their citizens by introducing this role into their nursing community. The selection of public health nurses as the first students to be educated was based on the fact that in the USA these nurses were already independently making diagnoses and working without physician supervision and using written guidelines for referral of patients. By adding to the PHN's current knowledge and given a few new tools, their practice would benefit the children attending these clinics and allow safe care to be delivered. These foundations shaped the program that followed. This program was created and provided as a continuing education certificate program for registered nurses. The NP program was not within a school of nursing or medicine. The development of a formally approved curriculum and finding a place within the schools while moving toward a graduate degree level took over 15 years. By 1980, it was being suggested that the NP preparation should be at the master's level. The National Organization of Nurse Practitioner Faculties became the lead professional organization that delivered models for programs, curricula, and the requirements for the NP practice. Opposition to this new role was loud and nasty. Leaders of other health organizations were calling for new roles, and yet some nurses opposed the NP role. Some saw this role as selling out nursing and moving into medicine. Physicians saw this as a challenge to their role of patient care and the use of their tools to make diagnoses. Yet a segment of brave nurses continued to develop and offer programs preparing nurse practitioners. Dr. Ford saw that the role was following Virginia Henderson's definition of nursing, an extension of the patient and not becoming a physician. Go back and reread Henderson's definition. As a CE program, a format of 4 months of theory and supervised clinical practice was then followed by 8 months of supervised clinical with a physician preceptor in their practice or their work setting, and then a successful final examination by the students led to an NP certificate. These programs were accredited by the American Nurses Association. Often, organizations and the federal government supported the programs and healthcare agencies where students were learning to be nurse practitioners. Philanthropic organizations also supported the beginning nurse practitioner education programs. By 1987, the federal government had spent $100 million for NP program development and nurse practitioner education. Ford and Silder and NP development faced additional challenges, including the legal legislation that had to be put in place in 50 states. That is, the change of the scope of practice and the role of the nurse 50 times over. Basically, the definition of nursing in each state had to be broad and not limited to the identification of tasks or procedures. This has taken years, since diagnosing and prescribing medications were eventually added as activities to the NP role. Medicine extended their opposition by requiring supervision of the nurse practitioner as their way of control. The public took time to accept the NP, but once they learned how the NP functioned and the care that they delivered, they have been our best advertisement for moving the NP role forward. Physicians eventually began to collaborate, their first group being pediatricians, as they knew the Well Baby clinics had already been run by nurses for many years. An example of the legal pursuit of medical opposition was in a suit filed in one of the states for a nurse practitioner practicing medicine without a license. That was in 1985. Dr. Ford's way of managing this was to appear on a national TV debate with the president of the National Academy of the Family Physicians. Dr. Ford pointed out that first, patients receive better care when the NP and MD collaborate. Second, the NP is not a substitute for a physician, and physicians are not a substitute for nurses. Third, that medicine wants to claim all health care without recognizing the contributions of other disciplines. And four, that the charges in the lawsuit against the nurse practitioner were financially motivated. The doctor who she was debating finally agreed that yes, we must have to begin to look at another title of provider. And the case was decided in favor of the nurse practitioner. By 1989, most nurse practitioner education had moved to the Masters of Nursing level and is now included in AACN standards. The National Organization of Nurse Practitioner Faculties at first worked alone, establishing guidelines for curriculum and clinical hours for education and practice. But then they jointly came with the AACN program for accreditation. Now, AACN has proposed the DNP should be the degree of education necessary for the NP role. National organizations that supported the NP role grew rapidly. Specialties started their own organizations, and additional academic organizations started. The groups were growing in multiple directions, and programs were growing of different specialties in multiple directions. Therefore, the National Council of State Boards of Nursing called for a consensus model, which was limited practice categories by population focus, such as pediatrics, family, maternal health, etc. At the same time, voluntary professional certification of the NP became a requirement in many states and work settings. Certification evolved as the early years of the NP development as an examination that assured for competent and safe nurse practitioners. Now, many states require national certification to practice in their state, as well as many NP positions require that the nurse practitioner be nationally certified. An academic degree has curriculum guidelines and outcomes, but the certification continues to validate the translation of theory into practice and determines the safety and the competency of each nurse practitioner. The NP role has expanded to the point of becoming a fixture in the current healthcare system in the United States. Because of the need for added primary care personnel and an increased demand for NPs in the system, independent practice out from under the control of the physician is the current goal in the United States. NPs are asking to be able to practice to their level of education that is supported by academic and practice credentialing. Organized medicine is still opposing and wanting to control the practice of NP, regardless of the amount of research that has demonstrated that NPs are safe and competent. Being a large nation, this will take time to evolve. It is following the path of the original acceptance of the NP practice laws in the 50 states. Most of the states that are classified as rural recognize the role of the NP, accept the care provided, and have allowed the independent role laws to evolve. While many diverse populated states will take much longer to pass this legislation, but we have 27 states that have now agreed to allow the NPs to practice independently. So where does a nurse practitioner stand today? We have 355,000 licensed NPs in the United States. 88% are certified in primary care. Of that 88%, 70 are family nurse practitioners. 83% are managing Medicare and Medicaid, which is our national insurance program. 96% prescribe medications in full-time practice. The founder of the NP program, Lee Ford, is 102 and still going strong, encouraging NPs to keep going forward. Here's a picture of my colleague and mentor when she was dean at the University of Rochester before she retired. I'm sorry I could not insert a more recent photo, but I'm technologically handicapped. Now moving from the NP to the DNP, I first want to review the organizations that influence nursing practice and the education of nursing in the United States. First, we have our parent organizations, the hospitals, colleges, universities, or private corporations. They monitor when the nurse is employed in their facility or going to school within their facility. The State Department of Health, or the Board of Nursing, issues mandatory licensures, which I've discussed. And this means that every person who practices their field of healthcare and nursing, whatever level, must be licensed or hold a certificate. That is good. That means they have to continue with their continuing education courses, etc., which are renewed every several years. And then there are professional organizations where the membership is voluntary. There are national nursing associations such as the American Nurses Association and state nurse associations. There's the National Council of State Boards, which I mentioned, which tries to keep all the nursing boards around the 50 states and the professional organizations together and on the same track. And then there are accreditation agencies, general with American Association of College of Nurses, which we've talked about, and then the National League of Nursing. And then there are certification organizations for postmaster specialties organizations. ANA and other organizations fall into that category. So these are the people and the organizations that have an influence on our practice, regardless of the level or the academic degree. The accrediting body that I will focus on is AACN, or the American Association of Colleges of Nursing. And the website is www.aacnnursing.org. This organization has a separate working group that assists in accreditation schools when they have to make a visit to see if they are meeting the standards. This group is called the Commission of Colleges of Nursing Education. Accreditation is a voluntary process for the schools to pursue, but the state boards of nursing, when they are processing a nurse who is wanting to have a license to practice in their state, one of the criteria does state that the nurse must have graduated from an accredited school of nursing. So this is questioned. It's voluntary for the schools to pursue accreditation, but it's not voluntary for the nurse who has completed a program unless it has been accredited by accrediting body. In early 2000, major health-related organizations called for a relook at nursing education and an accelerating the output as their shortage of nurses remains unfulfilled. The complexity of patient illness was increasing, and their management had become an issue, as well as scientific advancements requiring nurses with more and different education. These are the contributing issues, along with the need for a non-research focused doctoral degree that AACN pursues the DNP. One of the initial tasks was to define what degree would entail and that it was clear that this was a practice doctorate and that practice had to be defined. This definition is the vision of what a DNP graduate would be able to master and the roles where the DNP would be implied. Direct patient care, diverse populations, management of healthcare in all populations, administration of organizations, active policymakers. The DNP is not a research-focused doctoral program. NOPF had spent years of working on competencies of nurse practitioner practice in direct patient care management as well as diverse populations, and the collaboration between AACN and NOPF helped to bring the DNP expectations together. There continues to be a demand for more clinical faculty to teach the program preparing NPs, and especially with advancing the DNP as entry into practice. Another often ignored purpose was to establish parity with other health professions. Medicine is at a doctorate. Nurse anesthetists have moved to a doctorate. Psychologists and social workers are also at that level. The NP would move the nurse practitioner into the same level of education as their healthcare colleagues. This can also be viewed as a link for nursing's social recognition of professional status or parity at the doctorate level. After much discussion, surveys, and open meetings, the task force provided these recommendations to the board of AACN. There are 7 essentials that make up the foundation for the DNP. These essentials also are part of the basis for the new essentials that are recommended for nursing education at all levels. These foundational areas for nurse education are called domains and are supported by 4 spheres of care and 8 concepts with subcompetencies. For more information, you may want to go back to the website of the AANC organization. The 7 essentials that are listed on the slide can be found within the current new essentials, which I will give you at this time. First is nursing knowledge of nursing practice. Second is person-centered care. Third is population health. Fourth is scholarship of nursing practice. Fifth is quality and safety. Sixth, interprofessional partnerships. 7, systems-based practice. 8, informatics and healthcare technologies. 9, professionalism. 10, personal, professional, and leadership development. These 7 essentials are included in the new essentials that are based for the DNP program to go into effect. Additional suggestions for the DNP that the task force spelled out are on the screen. Also, these suggestions for the transition to the master's degree graduates moving into DNP programs, as well as assistance for schools moving to this level of education for advanced practice nurses, are expanded on the website. We're looking at, these are additional task force suggestions that the DNP program address. AACN set 2015 for the closure of all MSN programs preparing NP students to transition into and offering the DNP level for these students. Tools for moving to this level of education were provided by the organization. The new essentials for guiding the program were completed by 2006. In 2014, AACN commissioned the RAND Corporation to conduct a survey to determine the progress of schools closing the MSN tracks for nurse practitioner education and moving the students into programs offering the DNP. Some of the data that shows the progress along with the development of the DNP and the closing of the MSN programs to move to the DNP is on your screen. 341 programs offering the DNP had been accredited. In 2015, transition from the MSN to the DNP was slow and halting. They had not completed to the date. Multiple types of entry programs into the DNP evolved. Postmaster to DNP, the BSN to the DNP, and pre-licensure RN to the DNP. Between 2020 and 2021, enrollment in the DN programs increased from 39,000 to 40, and graduates increased from 9,000 to 10,000. Students opting for enrolling in the MSN level programs in 2004 were 10,737, while in 2018 they increased to 46,622 students. 10 years into the DNP transition, graduates of the DNP program opted to return to their positions in administration and education, as opposed to clinical practice with the doctorate. Another issue has been that the post-BSN enrollees have increased from 1,600 in 2009 to 18,240 by 2018. And this has caused issues with faculty. They are trying to teach advanced practice postmaster students and post-BSN students with little or no clinical experience in the same classroom. Another factor that has been identified was that the essentials do not clearly address the DNP expectations and outcomes versus the master's level outcomes. So why move to that degree? The exploring of the economic aspects of the doctoral education was not reported, and maybe this is an area that should be looked into when moving from a master's program to a doctoral program for both the school and the students and the employers. These are some additional critiques by an article by Macaulay and pointed to areas that may be why their transition has not occurred. And briefly, they need nurse leaders to come to consensus. They need to collect employment data. The credentialing and the certification bodies need to develop criteria for the doctoral level, and outreach is needed to increase awareness among employers about the DNP. On the positive side, we need to look at some of the things that have evolved with the graduates. They have certainly, those that were employed within COVID areas, have certainly been able to help gather the information and their expertise in managing the disruptive factors during the pandemic. Also improving access to health care and health equity. And then the National Organization of Nurse Practitioner Faculty has committed to transitioning entry-level nurse practitioner education to the DNP degree by 2025. So what are our future quests? The NP role will achieve independent practice status in all 50 states in the USA. I'm not giving a deadline date. That more tools and support systems have been developed by AACN to encourage the transition of the MSN to the DNP. And that the new DNP Essentials have been published and go into effect in 2024 with 10 domains, 8 concepts, of which evidence-based practice is included. Thank you for listening to the presentation. And if you want to contact me, here is my Gmail account, rtgoodyear@gmail.com. Have a good rest of the conference. Thank you and goodbye.